Our next speaker today is Dr. Seema Lalani, a professor and clinician geneticist at Baylor College of Medicine, who actively sees patients at Texas Children's Hospital in Houston. And it was Seema's clinical and scientific work that first led to the discovery of TANGO2 disease in 2016. As a board member of the TANGO2 Research Foundation, she's been a leader assisting families, clinicians, and scientists in advancing TANGO2 research. So please help me give a warm welcome to Dr. Seema Lalani.
What an inspirational talk. I loved how he said, find Superman within you. What are your unique capabilities? So I love that. So I have no unique capabilities, but I was part of a group that discovered the TANGO2 disorder in 2016. So it was a team effort, and again, it's great to be here. And again, nothing is possible if we don't work together. So I really believe in that. Okay, so for the next 10 minutes, my job is just to talk about the basics of TANGO2 disorder. I have no financial disclosure. And again, I'm going to talk about TANGO2 in a very basic way. So I'm sorry if it's too basic for some people, but I think it's important to have just this understanding. And you will hear very exceptional talks in the rest of the program. But I wanted to just start with some of the basic concepts. So human body is made up of trillions of cells. We all know that. And if you take one of these cells, as I show you here, the blue circle is the nucleus in the cell. And inside this nucleus are what we call chromosomes. So we have 46 chromosomes, 23 pairs of chromosomes. And TANGO2 disorder is related to the small chromosome that I have highlighted, chromosome 22. So the chromosomes have thousands and thousands of genes. We have about 20,000 genes that are all packaged on these chromosomes. So if you unravel one particular chromosome, you're going to see multiple genes. And I'm just putting this image on for you to see that TANGO2 is this one gene out of 20,000 genes that is located on chromosome 22. And again, as I showed you, chromosomes are in pairs, so everybody has 2 copies of TANGO2. So sometimes we hear that I have a TANGO2 gene. So I wanted to clarify that everybody has a TANGO2 gene. Everybody has 2 copies of TANGO2 gene. So what we really want to say is there is a problem or a mutation in those 2 copies of TANGO2. So you need to have both copies affected to have the TANGO2 deficiency disorder. You will also hear it as TDD. So just so that you know, we use these terms interchangeably. So if you have one copy affected, you will not have TANGO2 deficiency. You need to have both copies affected to have the disorder. And that's why we call it a recessive condition, which is different than a dominant condition in which you need only one copy to be affected. So TANGO2 disorder is a recessive disorder. So here is one example of a healthy person having 2 copies of TANGO2. TANGO2 must have a very important function, right? Because people are healthy when both copies are healthy and working. And then you have carrier parents, and many of you come in that category where your one copy of TANGO2 is perfectly fine, but the second one has a mutation in it. You would be walking around, you would be healthy, expected to have no major medical issues, and many times you won't be aware that you are a carrier. So when 2 carriers come together, there is a 25% chance of the child to have the TANGO2 deficiency disorder. And here you see that both copies are not working in this affected child. Same concept here, 25% chance. And again, this is a risk which is present with every pregnancy. It's not like you will have 3 healthy children and then 1 child affected. It's not like that. You could have 4 affected children in a family. Every time it's a 25% risk. So now, what are the type of changes that affect the TANGO2 gene? So I usually explain to families this way, that imagine a big giant book which has 20,000 pages. One family said, I cannot imagine that book, but yes. So 20,000 pages, which means 20,000 genes in this book. And the type of changes we see in TANGO2 is, the most common is 1 page of TANGO2 gene, we see 2/3 of the page is gone. And in scientific terms, it's called exon 3 to 9 deletion. So most of the gene is just deleted. So this page would just have little bit writing on the top, but everything else is blank. So that is one of the common deletion mutation that we see in our families. And we see this more commonly in the European families, but any population can have this deletion as well. Here is just a figure of what TANGO2 gene, the exons are the coding part of the gene, which are the most important part of the gene, and you can see that it ranges from exon 1 to 9, and the deletion exon 3 to 9 pretty much takes out most of the gene. What are the other kinds of changes? So again, going back to the analogy of the big giant book with 20,000 pages, with TANGO2, one of the pages, it can just be that the whole page is fine, but there is a misspelling, and that is enough to cause the gene to not work properly. So we see this in many of our Hispanic families from Texas, and if I have the pointer, but it's basically just a misspelling where G becomes A, and that is enough to make the gene non-functional. So as I said, we see that most commonly in the Texas families, but there are several other changes that can affect the TANGO2 gene in any other way. It can be a deletion, again, missing a paragraph, it can be a misspelling. And then I wanted to just bring this up about, another category of children we are now seeing with TANGO2 deficiency. And these are children who also have another kind of problem, and they have 22q11 deletion syndrome. I'm bringing this up because we have seen in our natural history some children who actually have 2 disorders, the 22q deletion syndrome plus TANGO2 deficiency. I wanted to explain how that happens. And then throughout the conference, you will hear talks and poster about this particular group. So children with 22q11 deletion syndrome, you may also hear as DiGeorge syndrome, they have a separate set of problems. So what happens in them is they have a deletion or a missing part of chromosome 22. So the TANGO2, 1 copy is missing, but there are many, many genes that they are missing as well. Usually their second copy is intact. So second copy of TANGO2 is intact. That's the usual case. So they would just have problems related to 22q11 deletion syndrome, and I've listed some of them. So born with a heart defect and other problems. Very different than our TANGO2 kids. What happens if their second copy is also affected? What happens if their parent is a carrier of the 3 to 9 exon deletion and they inherit that as well? So now this child would have two conditions. Already was diagnosed with the DiGeorge or 22q11 deletion, but is now also going to have TANGO2 deficiency. And all the problems related to TANGO2 deficiency will be seen or may not be seen. And that's something we are trying to understand, like how do we find these patients from the 22q11 group? Because they look different, they have different set of problems, yet they can still have metabolic crisis, and that can be life-threatening for them. So there are a few children who have both conditions, and this is something that we are intensely working on to find these patients because they are right now hidden. So presentation of TANGO2 disorder. I wanted to just show you that all these data have come from you. So the natural history study that you participated in has now allowed us to come back and tell you these are the aggregate data that you've provided us. that, you can actually have 3 kinds of presentation for TANGO2 deficiency disorder. And families have told us that these are some of the common problems that they are seeing in their children. Intellectual disability, learning problems, baseline gait abnormalities, difficulty with speech, so it could be slurred speech, articulation problems. They can have seizures, epilepsy, hypothyroidism, low-functioning thyroid gland. They can have crossed eyes, strabismus, but important thing is their heart is normal at baseline. TANGO2 spell. So I still remember in 2019 conference when we were all here together, and the researchers and investigators were not aware of this particular part, TANGO2 spell. And I remember Amy Clay, she said, I want somebody to tell us about these intermittent random episodes that are happening to our children. And I'm like, what are those? And then that opened up a whole thing of, a whole set of presentation that we were not aware of, because these are intermittent. By the time you get to a doctor, these usually disappear. And so families have struggled, to bring this to attention of the doctors. And I would argue that this is the time when doctors need to find these patients from these TANGO2 spells, because they are so characteristic. We want to find these patients before they have their metabolic crisis. And so families have told us that these spells can be like intermittent head tilt, body tilt, extreme fatigue resulting in drooling, swallowing difficulty, gait abnormality. And they've not been able to understand this. We have learned that, feeding them during these episodes or letting them rest makes it a little better. And you will hear more about that from Dr. Miyake in the natural history study talk. And they usually return to baseline. Important thing is that if you take your child to the doctor or to ER, all the labs are going to be normal. So no hypoglycemia, no elevated CK, and it's just an episode. And it's interesting that, even the metabolic physicians are now calling us, and they're like, do you see mental status change in TANGO2 spell? I'm like, yes, definitely. You see mental status change, and it's not a crisis, it's just a spell. And then, of course, we all know about the metabolic crisis, which is the severe end of presentation, and this is what we want to prevent. And again, going back to 2019 conference, families were terrified of this metabolic crisis, cardiac arrhythmias, and they didn't know how to prevent those. And I am so overjoyed that we come to this third family conference and families feel that, they have control over this with the vitamin B supplementation. And so we've come a long way. But, so let's talk about how these happen. So these can be precipitated by acute illness, not eating well, not drinking well. So fasting and dehydration can cause this. And again, these children, similar to the spell, can have altered mental status, difficulty walking, can even be in coma and just disoriented, and they are brought to the ER, and here you will see all kinds of lab abnormalities. So glucose would be low, could be low, you have elevated CK. By the time they have high CK or rhabdomyolysis, they are in metabolic crisis. So this is how we define it. And then during this time, if they get the heart EKG, heart rhythm check, they would have abnormality, which we call prolonged QTC. It can be life-threatening. Developmental regression has been reported by families. Like once the child gets into crisis, then it can take several months or years for the child to come back to what was baseline or may never be able to. And this is what we want to prevent. In terms of management, for routine management, you might have all these doctors taking care of your children. So it could be a hormone doctor, endocrinologist taking care of the thyroid issues, a neurologist taking care of epilepsy or movement issues, the spasticity, the tightness, the dystonia that we are seeing. You may have a developmental pediatrician in your team. You would definitely have therapists taking care of children, physical, occupational, speech therapist, and maybe a physical medicine and rehab doctor who is managing the tightness with Botox and other ways. And then a cardiologist who will keep an eye on the heart during the time that the child is well. And again, we know the circumstances to avoid fasting, avoid dehydration, and avoid ketogenic diet. And we are really glad to see that most families in this room are aware of the emergency protocol, and they have taken this to their ER doctors to actually guide them as to what to do with their children. So this is my last slide. In summary, I want to emphasize that doctors have to learn that neurological problems would be the first manifestation of TANGO2 deficiency. And it is our job, to educate others that please diagnose children during their baseline problems, during their TANGO2 spells before they get into metabolic crisis. So early diagnosis is the key. We all believe that we can improve health outcomes with early diagnosis. And we've also learned that bad arrhythmias and then cardiomyopathy, where the heart is not functioning well during crisis, may all be reversible if you know how to treat them. And we have done our level best in disseminating this information through gene reviews and other platforms so that doctor in any part of the world could see that and see how to treat children in metabolic crisis. And of course, natural history study, thank you all for participating. This is the reason why we know that vitamin B complex works for our children in preventing these crises. So thank you very much. I'll end here.